TopMedTalk.
Well, hello and welcome to TopMedTalk. We are coming to you live from EBPOM, Ireland at the Skellig Hotel in Dingle, Ireland. Now, I'm Desiree Chappell. I'm managing editor for TopMedTalk. I'm a CRNA, or Certified Registered Nurse Anesthetist, and I'm Vice President of Clinical Quality for North Star Anesthesia. And joining me today in another place, but still Ireland, is my co-host, Monty Mythen. Monty, hello. How are you?
Hey, Desiree, it's great to be here. This is one of our pre-records. We're actually both in the Skellig Hotel now, and the crew is just putting all the equipment together for us to go live relatively soon. And we were going to be doing this from our pop-up TopMedTalk studio, but we just pushed our luck a little bit, because we're in a few hours now of the go live, and we're not quite ready, but nearly ready. So here we are. Let's game on.
That's right. So we're excited to be having some wonderful conversations on the TopMedTalk adjacent to the main stage, but on the TopMedTalk stage for EBPOM Ireland and EBPOM Chicago. And one of the fabulous conversations that we're going to have today is about sedationists. So it's my pleasure to introduce our guest. It's Professor Rob Sneyd, who's coming to us from Cornwall. Unfortunately, not here in Dingle, but we will definitely take it anyway. Professor Sneyd, it's so wonderful to see you.
Thank you, Desiree, and thank you for the opportunity to join the EBPOM meeting. I'm also very excited to engage, and sorry I can't be in Dingle.
I know, we hate it, but you're actually going to be on the main stage as well, or your presentation and conversation will be as well. So we have integrated you despite your absence.
So Rob, you have joined us here in Dingle before. Just from your perspective, a little teaser for people. How did you find it?
I love coming to Dingle. First of all, it's about people and it's about content of the program, but there's no denying it's in a fabulous location as well. I come from the southwest of the UK, live by the coast. I tell my American friends we live in the Florida of the UK. If you've got to live in Ireland, then I'd say Dingle is a pretty top spot to be in.
Brilliant. Thank you very much for that. We're going to be discussing, procedural sedation, staying safe from procedural sedation. I think you gave us a title, which was Evidence Based or Tribalism. Now, procedural sedation, Rob, just to give us a little bit of context, why have you been interested in this over the years and decades? I know we'll get into the detail of it. And what's procedural sedation distinct from, an anaesthetist giving an anesthetic or an anaesthetist providing sedation?
Well, I think my particular interest in clinical sedation comes from my interest in anesthetic pharmacology, and procedural sedation is the particular instance of that. Where I think it's challenging is that it sits at a nexus or a crossroads of professions, of procedures, of patients and their characteristics, their phenotypes, even their genotypes. All these things come together in one place. And then milling around in the background, we've got economic interests, commercial pressures, private practice considerations, regulatory changes, and they all come together. And in the middle of it, we've got to keep track of our priority, which of course is patient safety as number one.
So can you expand on that, Rob? You say patient safety number one is obviously that's our sole priority, but are there other priorities?
Completely. So our top priority must be safety, but also we need to think of the quality of the patient experience and the quality of the experience from the clinician who is serving the patient. And then from the hospital's point of view, they're interested in throughput for the clinic or the session, and they're interested in economics. So we can consider all of those. They all bump into each other. When we focus on safety, I think the headline, or the most obvious one, is acute things, by which I mean disasters, typically cardiorespiratory compromise, often catastrophic. I think increasingly, we've also got to look into optimization of the patient experience. So in the perioperative medicine domain, we're now very focused on hypotension. And I'm pleased to see that you got a major spotlight on that during the meeting. Up until now, nobody's taken any interest at all, really, in patient monitoring during sedation, other than to prevent catastrophes, which is where the pulse ox and the capnograph help. But I think we should be taking a lot of interest in patient blood pressure.
So last question from me at the moment. What's changed in recent years? Because I just think back my personal experiences. At one stage, I went to the dentist, and the dentist gave me, I was very young at the time. I didn't really know what was going on. Mum was looking after me, but I think they gave me some midazolam or something similar, a benzodiazepine, and I was a bit doolally afterwards, but it all seemed to go fine. And then much more recent years as an adult, I've had a colonoscopy, for example, and I'm not sure there was I know there wasn't a professional there as an anesthesia provider, but I was knocked out a little bit. What's been changing?
Well, you were probably in the hands of what I call a sedationist, but as one who writes a lot about it, Microsoft Office always changes sedationist to seditionist. So I found myself describing consultant level sedition on a number of occasions. Anyway, we'll not dwell on that. I think what's changed is that sedation is now ubiquitous in clinical practice. It's in every corner of the hospital, wherever you go. We published a few years ago, 2015, a snapshot of 6 general hospitals in the southwest of the UK. We got our residents to collect data over 2 days in every corner of the institution. Our youngest patient was 1 year old and the oldest was 96. They ranged from the obvious places like the operating room and the cath lab through to the infertility suite, the children's ward, all kinds of strange places where we didn't even know sedation was going on. And so there's more of it. It's in more locations. Clinicians are becoming more ambitious. Patients are becoming older, larger, and more comorbid, at least as they're presented to us. So these things provide a perfect storm. And at the same time, we haven't got enough faculty to present a medically trained anesthesiologist or even a nurse anesthetist, Desiree, to sedate all of these patients. And so we have to not be too pious about it. We have to support our colleagues in other disciplines who mostly are interested in doing a terrific, safe job for their patients and help them to get the right quality of experience with the safety layered into it.
Yeah, it actually, Rob, it's really interesting. As a nurse anesthetist, part of my practice is just doing sedation for colonoscopies and doing sedation for these procedures, and which has definitely been an evolution over time. And especially since with the use of Propofol in this space and having that just used by anesthesia providers instead of nurses or even the physicians themselves, that has changed a lot. And personally, I have just seen a change in patients over time as well. And I mean, it's definitely what we can do in the, endoscopy suites. We're taking on a lot more challenges than we have before. And, you had said that this is a safety issue. Now, can you tell us a little bit more and dig a little bit deeper on, patients still being injured? Because, you would think adding, specialized providers in this space that it would be a little bit more safe.
So the master paper was one by Quine, which was decades ago now, which really pulled up the red flag and said things are going badly wrong in the whole domain of procedural sedation. And to be fair, we should not hector our clinical colleagues with Quine because it was decades ago and things have moved on since then. It's had enormous consequences. So certainly in the UK, every hospital specialty, bar none, now has an element of sedation training included in their national curriculum for their consultant post. There are agreed standards about monitoring, about training, about audit, about patient consent, follow-up, equipment, personnel. So things are immeasurably better. But having said that, there are still bad things happening on occasions. And whilst nobody goes to work in the morning planning to harm a patient, I truly believe that. Nevertheless, there are some instances where practice, which is not of the highest order, presents opportunities for patient safety to be compromised. And if you do that often enough, bad things will happen downstream of that compromise. So we have to step back, set our focus on the only set of standards are high ones, the only set of interests are the patient's interests, the only set of priorities is the patient's safety. And if we keep our eyes on those things all the way through, then we can reduce the modest haul of bad things to hopefully immeasurably small. That's our ambition, is that nobody is harmed.
Yeah, absolutely. It is, patients are just a lot more challenging to take care of. I mean, you have, especially when you're using propofol sedation or you're, integrating narcotics into that with, CO2 narcotization, especially in our sleep apnea patients and our larger patients. Talk to us a little bit more about the monitoring that is, now becoming more of standard of care for sedation.
Thank you. So monitoring was really the first major observation out of Quine, apart from the fact that they've got both deaths and patient injuries, the monitoring was extremely inconsistent. Many of the patients then weren't even monitored with a pulse oximeter. And of the four out of the 5 patients who had cardiorespiratory arrests in that series hadn't even got a cannula in. So we have come a long way since then. It would be pretty extraordinary, I think, almost anywhere on the planet for a medically sedated patient not to have a pulse oximeter attached to them. It's absurd. You can buy them for $20. So there's really no reason not to do that. I think the next trick, though, is about situational awareness for the clinical team in the sedation environment. And I bring to your attention particularly capnography. I think this has moved on immensely. There's now a fantastic new kit, lightweight, simple monitors, easy to use, and with an integrated soft rubber, not unpleasant nose piece, which both delivers oxygen and measures the patient's respiration at the same time. So in a simple monitor that is, shall we say, nurse-friendly, not terrifying like an anesthesiologist's monitor, you can have a waveform showing that the patient is breathing, and you can have a waveform showing they've got pulsatile flow of oxygenated arterial blood to the periphery. And by and large, if you can achieve those two things, and better still, they're still responding to verbal contact, you're more or less in the right place. And I think that not only is that of value to the sedationist or the person who is monitoring the sedated patient, the broader dimension of the whole team having a shared understanding of what is going on, and that the patient is safe, and they all know why they know that the patient is safe, is one we need to talk about. Situational awareness has spread from aviation. It's something we talk about a lot in anesthesia as a whole. And I think it's very, very important for the sedation experience, where often we've got ad hoc clinical teams which have been assembled at short notice. There may be an unfamiliar clinician outside their normal environment, assisted by someone they've never met before, working with a physician endoscopist perhaps, or a physician surgical proceduralist. And if they don't know each other, then a good place to start is building resilience. And part of that is great monitoring with simple waveforms that everybody can understand.
Yeah, absolutely. I would say that monitoring has definitely changed my practice as we have adopted capnography as a standard of care for all sedation that we do, which is interesting to hear that is not necessarily universal these days.
So Rob, you touched on, and Desiree both touched on Propofol in passing. Now, there was a time when Propofol was we thought the strict domain of the anaesthetist, because it gave an anesthetic, but times I think have been changing. We'll come to new drugs in a second, but where are you on the Propofol issue?
Well, it's a really interesting story. Propofol use underpins increased participation by anesthesia services and outpatient colonoscopy. So if we go to the United States, in the decade from 2006, which takes us up to 2015, the anesthesia participation went up from 17% to 58%, a massive increase. And that was basically all Propofol sedation. And I don't want to be too cynical, but part of that is commercial interest, because it's a good earner. And that pattern is different, certainly in different European countries, according to the reimbursement schedule. And I think it's had a number of effects. So in the United States, there is non-trivial challenge coming from the top end of the gastroenterology bodies, arguing that they like their patients sedated with Propofol, but they don't like having to pay for an anesthesiologist to do it, or struggle with the availability. And the other side, particularly outside the States, I would say Germany is an exemplar, where there are enormous series of patients, more than 25,000 patients, safely sedated with low-dose protocols given by nurses using Propofol in small doses. And I wrote an editorial, in fact, pointing out that, at least in Australia, you may be better off with a nurse than with an anesthesiologist, because Kate Leslie published from Melbourne a series of almost 2,000 patients having either gastroscopy or colonoscopy. And in that, there were a considerable number of material adverse events. Lots of patients with hypertension, about 10% had significant hypertension, by which they meant blood pressure below 90 and needing something done about it, like a fluid or pressor. And the ones who are having colonoscopy, it was double. Okay, so there's lots of hypotension out there. And if you're given more Propofol, in this case by the anesthesiologist, you probably get more of it. And from some unpublished data that I'm working on at the moment with colleagues in Holland and Australia, it looks as if propofol sedated colonoscopy patients are experiencing episodes of hypotension whose depth and whose length is associated with bad outcomes in surgery. Now, I'm not saying that's the same thing in sedation, because surgical patients have a wound, they have inflammation, they have big fluid shifts, which may not apply. But I think we have to start taking the physiology of what we're doing to our patients during sedation more seriously. And so I think, I'm not saying we've cracked it, but we are certainly right on the case about the basics of airway obstruction, the right people in the right room and the right procedures. And now we want to be fine-tuning to avoid making a 75-year-old with comorbidities experience a hypertensive episode that they didn't need.
I just clarify, Rob, when you said nurse, because we've talked about nurse anaesthetists, I think you're referring to not a nurse anaesthetist.
Certainly in the German experience and also in Holland, I would say nurse, yes, with specified training. It is very political. So if we go back 15 years, the European Society of Anaesthesiologists produced guidance on NAAP, non-anaesthesiologists administration of propofol, which had to be withdrawn, not because it was academically unsound, but it was politically unacceptable. The national member societies weren't having it. Fast forward to much more recently, and a more measured view is coming through. And I was looking at a paper yesterday reviewing guidelines, because there are any number of them, and that increasing number of national bodies across many countries are now sort of coming to terms with the fact that actually, with competency-based training and a sensible team situational awareness approach, it is perfectly safe for a well-trained nurse to give small dose propofol and effectively sedate patients for procedures.
But I just want you to briefly, and we'll do a longer form interview, which, once we finish this one, which we'll make available to people to listen to, about novel agents, because Sure. For a number of years you've been telling us about novel drugs coming along. And we're not going to go into detail in that at the moment, but if you could just touch on remimazolam, for example.
Well, it's an exciting time, and there are two new agents actually knocking around. So one is remimazolam, which I'll come back to, and the other, whose spelling I was just checking, is oliceridine, which is a novel opioid which allegedly causes less respiratory depression. And that's kind of about all I know about it at the moment. So remimazolam, very interesting compound, incredibly slow development. It's a spin-off from Glaxo Wellcome. When they developed the same ester technology that makes remifentanil work, they produced remimazolam. Glaxo got completely uninterested in anesthesia, shunted the molecule off into a Cambridge company called Senes, and it ended up with a small German company called Pion, who've had a slow development. And it is now finally licensed for procedural sedation in the United States, for procedural sedation in Europe and in the UK. Sadly, we're not Europeans anymore. And it's licensed for anesthesia in China, Korea, and a number of other properties as well. So that's an interesting story. The dimensions of it are that the pharmacodynamics, that is the drug effect of remimazolam, is basically the same as midazolam. It does that. If you look at a patient who's sedated with one or sedated with the other, you really couldn't tell the difference. So it's all about the time series. So the peak effect of remimazolam happens in a couple of minutes. So that's about twice as long as propofol, a little bit longer than propofol, and it wears off considerably quicker as well. So that you've got a benzodiazepine style sedation, which you can get to quicker and which you can get out of quicker. So the headline case there is for the endoscopy suite, where it may be possible to deliver increased throughput. And I think it'll be interesting to see in the United States whether the opportunity to have a high throughput but good quality patient experience may displace back some of the propofol sedation that's been expanding so rapidly. And then looking further ahead, and remembering that it's not licensed for anesthesia in Europe, people have been experimenting with benzodiazepines as induction agents for sick patients for many decades. From 1966 was the first report of using diazepam, the archetypal benzodiazepine, as an induction agent for anesthesia with minimal hemodynamic change, then to midazolam. And they both work. The difficulty is they take forever to wake up at the end of the case. So that doesn't really work. And if you reverse them with flumazenil, you then get resedation. So that's not a great idea either. So I think remimazolam has two opportunities. One is as a induction agent for sick patients, perhaps, and certainly in the States where anesthesiologists are still quite wedded to etomidate, which is a rotten, poisonous drug. They might want to have a little think about that as an area for development, but I stress it's not licensed, but it's one to be thinking about. And then I think the big ticket story about perioperative hypertension in total in anesthesia has becoming more and more important. And the preliminary data, sadly, only reported as a press release from the major European registration study, phase 3 study of Propofol versus remimazolam, is reported as showing considerably less adverse hemodynamic events in the benzodiazepine group. So I think there's some exciting stuff to think about, but the case needs to be made.
So Rob, so much has changed over the last just 10 years, 5 to 10 years in this space. Where do you really see sedation and the practice of sedation going and, changing over the next decade?
Well, that's a great question. I think the first thing is that our clinical colleagues will continue to become more ambitious. They're going to want to do bigger procedures on sicker patients ad infinitum. So that's not going to change. I think that we have the opportunity to revisit automation. We have had now working closed loop general anesthesia systems for 30 years. They're not quite commercialized. Target controlled infusion is alive and well on the whole planet, except the United States, sadly. And I think the tidal wave of AI application to medicine will find its way also into the perioperative experience. So I can see further developments in electronic brain monitoring, drug administration, aligned to signal and data processing having a role. That's the first thing. But I talked about the collateral damage, the big deadly hits, the cardiorespiratory arrest. That's the headliner. But the more seditious, I'm back to sedition now, patient injury story, particularly induced by hypertension and possibly by other effects of medications, is something we're going to have to look at really carefully, because we are exposing vast numbers of patients to propofol sedation for colonoscopy. It's a mega industry worldwide. And so if something happens only 1% or 0.1%, that there's badness happening, then actually there's quite a lot of people being caught up in that fishing net, and we need that not to happen. I think oliceridine, if anybody can spell it, sounds great. I particularly like the idea of reduced respiratory depression, because we know that most procedures don't lend themselves to monoagent sedation. Most non-trivial procedures, it hurts a bit. So if you're having colonoscopy, the distension, etc., is painful, and it needs an anti-nociceptive of some description. And it is that opioid element that gets our colleagues into so much trouble. I was a junior doctor in a hospital in central London when our radiologists discovered alfentanil, and the anesthesiology and radiology departments had to meet under a white flag of peace, at which they officially surrendered all their remaining alfentanil supplied and said that they weren't going to use it anymore because they'd had so many disasters. And that was fine. But, we need to help our colleagues provide decent analgesia. And if oliceridine turns out to be a little step in that direction to breaking the link between decent analgesia and respiratory depression, then that's a very exciting development.
Absolutely. Rob, thank you so much for joining us today for this conversation about sedation. I think there's a lot more to be had for sure, and look forward to continuing this conversation in the year and years to come. Everyone out there, thank you for watching, and thank you so much for joining us at EBPOM Ireland in Chicago. Monty, that's a wrap.
That's a wrap. Great to see you, Rob.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.